Great, thank you very much. And thank you all for being here today. My name is Megan Gallagher. I'm the Monitoring, Evaluation, Research, and Learning Director for the Momentum Integrated Health Resilience Project. And I'm really excited to have two speakers here today to talk about shocks, stresses, and health outcomes, and to think about the role of promising health resilience strategies in fragile settings. And I think there is a lot of enthusiasm around resilience right now and thinking about how resilience links to health. We want to define resilience. We want to coalesce around similar understandings of resilience. We want to measure resilience in consistent, useful ways. And I think everyone is really, really excited about this topic. And I think as excited as we all are, I think there are still a lot of questions about what that ideal measurement looks like and how do we do resilience in programming, particularly thinking about resilience in fragility and in fragile settings. And so I'm very excited to have two speakers to talk both about what is resilience and how do we think about measuring it and how does it link to health, and then also how do we do it and how has MIHR done resilience work in our programming. Next slide, please, Pradisha. Before we get started, I just wanted to address some housekeeping points. So this webinar will be recorded, as you've seen. After the webinar today, the slides and recording will be available on the Momentum website. There is a lot of material today, so if you have questions that are raised during the presentation, please put them into the chat as we go so that we can get to them at the end. And English and French interpretation is available. If you are having trouble with interpretation, please ask our translation team and they'll be happy to help you. Next slide, please. So today we're going to focus on two main objectives. So as I mentioned before, we want to get a better understanding of health resilience literature and measurement, kind of where we are now. David Canning is going to talk a little bit about some of the work that they did, thinking about this a little bit further. And then we're going to learn how Momentum Integrated Health Resilience has applied this understanding of resilience work to achieve improved health outcomes. So there'll be two presentations. David Canning from Harvard will present first, followed by Isabelle Brumeau from MIHR, and then there'll be ample time at the end for questions and discussion. Next slide, please. So with that, I'm going to turn it over to our first speaker, David Canning from Harvard University. He is the Richard Saltonstall Professor of Population Science and Professor of Economics and International Health in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. His research focuses on the role of demographic change, for example, the effect of changes in age structure on aggregate economic activity, and health improvements, for example, health as a form of human capital and its impact on worker productivity in economic development. Thank you very much for being here today, David, and over to you.
Great. Thank you very much, Megan. Can everyone hear me okay?
Sound and clear. Perfect.
Great. So I'm going to try to go through this quite quickly so we have time for discussion. I'm an academic, a professor, so I like the methods, but I'm actually going to try to focus on the conclusions. So next slide, please. So we were asked to do two things, a landscaping and sort of figuring out where the field was at, but also some more quantitative work in 4 countries. And so we did a literature review, but I think one of the most important things we did is interview key informants and people in the field, experts in resilience, but also experts in the field about their views on resilience and what was needed. So next slide, please. I think people will be familiar with the different resilience measures. I think that we have the Tango measure, the FAO measure. So we were looking at health resilience, and these are measures that were developed for resilience more generally, but can be applied to health. And they tend to have a factor structure. They're based on a large number of variables, And resilience is sort of as a latent variable, which can be measured as a combination of other factors. And the exact domains and the exact measures differ, but there's quite a lot of overlap. And I would contrast this with the third approach, which is realized resilience, which is actually estimating the path of recovery after a shock. So the idea of resilience is after a shock, people who are vulnerable will have a bad outcome. But then if they're resilient, they will bounce back and maybe bounce back on track to where they were before. And empirically, the idea of realized resilience is to link the resilience measures that we have to how people bounce back after a shock. And so essentially, it's the pre-shock characteristics affect how people respond to shocks. Next slide. In terms of health, there are competing measures of resilience. So the Crook measure, who's part of our team, has 5 domains. Hatfield has 3, Shaw has 4. And so they tend to focus on slightly different issues. These are very concentrated on health system resilience, where the it's measuring resilience of the health system to shocks. That's only one dimension. We were interested in going down to the last mile. And there the other more household and individual characteristics in resilience are more important. But this just gives you a view that within the field, there are a lot of different measures. And it's almost as if each professor has their own resilience measure. And there's a lot of overlap between them. Domains are similar, the exact measures used are similar, but the way they're combined can be somewhat different. Next slide. I think from our review, we found FAO and Tango frameworks useful for constructing resilience as a latent variable. There's the ARC-D toolkit, which we think is very good for measuring resilience at the community level. And then health system resilience can be measured using indicators like Crooks. And these can be combined into a measure of overall resilience, which is a function both of individual, household, community, and more system level. And those measures of resilience are going to be highly multidimensional in terms of their inputs, but then they tend to come out with a single measure as an output. Next slide. So in the academic literature, there's a lack of consensus. There's a lack of literature on the sort of the last mile on actually getting resilience measures that cover all these dimensions from the individual, household, community up to the system level. And an overwhelming feeling that more evidence is needed. Next slide. We're also interested in the evidence base that these resilience measures actually work. These are latent variables that are constructed, but then what we want to do is see, do the people who have higher resilience measures actually respond better to shocks after and bounce back after a shock? This is actually a difficult area. There aren't that many papers in this field. You have to have data that is panel data. You have to have shocks and these baseline resilience measures. And then they tend to look at a large set of baseline resilience indicators and look at the multiple components of resilience and what each one contributes. But that's a very difficult estimation problem. And I'm going to come back to this later on and argue it may be an insoluble estimation problem to identify the multiple components of resilience empirically. Next slide. We then did key informant interviews. About half were academic, about half resilience practitioners. Next slide. I think one of the really important things to come out of the key informant interviews was this split in views between the academics and the practitioners. The academics very much had the view that there's a debate around resilience definitions. The measures are actually complex and difficult, and we don't have a resolution on what the measure should be. But the practitioners had a very different view. They had a general consensus that we knew the components of resilience in general, And they also took the view that the difference between these different resilience measures was fairly minor. And in terms of their view, the issue wasn't one really of definition and understanding resilience, but of implementation. So how do we improve resilience in the population? So it's moving to a more implementation strategy. And that the difference between the different resilience measures was not actually very meaningful. Next slide. They felt that communities were often best placed to respond quickly and efficiently to a shock, that there were standard characteristics of resilient communities, including strong community engagement, trust in the health system, working mechanisms, communication, and that the community context matters. And so I think they took the view that the components of the things in the resilience measures were correct, but the actual fighting over the details on exactly which resilience measure to use and the exact components, the exact variables in each of those factors was not terribly important. So a gap between the academics and the practitioners. Next slide. And so just to emphasize this point, practitioners felt there were sufficient and adequate measurement tools, and the main challenge lies in operationalization. And I think, the recommendation I'm going to have based on this is that we move to a consensus on a measure of resilience, and that rather than look for the perfect measure, which is what academics tend to do, that we look for a measure that is good enough. And once we have cohered on that measure, we use that to operationalize. And that the gains from improving the measure will be marginal, whereas the gains from focusing on a measure and using it in different settings and in different ways is going to be very large. Next slide. I'll now turn to the quantitative analysis we did in 4 countries. Next slide. This was to investigate the idea of using a pseudo panel of DHS. If you want to study resilience, you really need a panel data. You need to look at how people are before a shock, after a shock, and how they respond in the long run. We have a lot of data that is not panel. We have these cross sections from DHS, but they are repeated, and you can construct a pseudo panel out of these by matching people from different panels. I won't go into the technical details of that, but I think it's a potential way of getting a lot more empirical evidence on resilience from the data that we have. And so what we want to look at is how shocks affect health, how the time since the shock matters, and how people can bounce back. And look at how different characteristics of resilience matter. Next slide. These are the DHS surveys we used in various countries. So we need at least 2 surveys to look at resilience. Next slide. The shocks we looked at were climate shocks, extreme rainfall and temperature, and conflict shocks, looking at incidence deaths within 50-kilometer radius. And existing literature shows large effects of these shocks on child health. And we were looking at the effects of these shocks on maternal health, mothers, women aged 15 to 49, and looking if we could see time paths of responses to these shocks. Next slide. This shows some effects that we found for extreme climate. So the red are bad outcomes, the green are better than normal outcomes. And what we see is low rainfall and high temperature, which is drought conditions on the bottom left, is bad for hemoglobin. Whereas high rainfall is also bad on the extreme right for BMI. And that seems to be associated with high disease prevalence. So diarrheal disease can be greater when there's high rainfall. So I think you're getting multiple mechanisms here. It's a complex picture because you have both effects on agriculture, but also effects on disease. Next slide. So we do see this effect of drought conditions. Some extreme weather conditions seem to improve, and it's a complex picture here. Next slide. The big difficulty here is it's very difficult then to go on to look at resilience. And the exposures tend to be highly correlated across clusters. If a country has extreme weather in a year, most of the clusters are getting similar extreme weather. And some years, in some DHS surveys, there are almost no extreme weather events in a country. The same issue with conflict, it's highly spatially correlated and not present at different lags. And so if you look back and say, look at shocks a few years ago, we can look at those and then say, what is if it's a few years before that? Sometimes there are no shocks at all that far back. And that it makes estimating lag effects difficult in cross-section data, because at some lags, we don't have these shocks. Next slide. And I just want to highlight what I think I've figured is the really big problem in quantitative resilience studies, is that most of the studies I see in the health field are an exposure affects health. So you have an exposure and you have a health outcome. Resilience is essentially a three-way interaction. If you want to think about resilience, you need a shock. You then want to look at the lag structure. How does that shock affect people over time? How were they before the shock, after the shock, and then how do they recover in the longer run? And then you want a resilience measure, which is one of these resilience measures of what characteristics the individual community has that allows them to deal with a shock. And that three-way interaction then leads to health outcomes. But estimating three-way interactions is intrinsically difficult. And that's really difficult if the shocks are rare and highly correlated. They're sparse. And that gives us very noisy results. And so I think that we basically found that the repeated cross-section approach is theoretically possible, but incredibly difficult to do given the data structure. Next slide. I think there is a way forward for this empirical approach, which is maybe moving to larger numbers of countries. And we looked at 4 countries. If we had a larger number of countries, we might get a better model. Though I think this then raises the question of whether there really is homogeneity across countries. If we think of heterogeneity in reactions in more fragile settings, pooling may not be a great idea. Next slide. And I want to turn to recommendations. And coming back to what I said earlier, I think we should focus on one measure of resilience. And that common measure should be used across countries. And in terms of the link between the resilience measure and realized health resilience, I think that there really is no substitute for panel data studies. The repeated cross-section approach, I think, is just too limiting. And I would argue for something like a DHS plus. I think the field is sort of locked into the cross-section DHS, and the cross-section approach simply is not really good at measuring resilience. If resilience is the interesting question, you really need panel data, and I think we need routine panel data measures. The other issue is, I think, quantitatively, it's much easier to look at one resilience measure and resilience outcomes. So this actually links back to the one measure needed for implementation. There are so many resilience measures and there are so many dimensions. If you try to estimate which resilience measure does better, or to estimate which component of resilience really matters for health, it's too complex a question. It's too high dimensional. I think a more feasible question is, if we have one resilience measure, how does that resilience measure affect health outcomes? That's a feasible question. The empirical data will not allow you to distinguish between which is a better measure of resilience. There's simply not enough data points to do that. Next slide. I think it's not really possible to distinguish the best resilience measure. I think there's a lot of work on the psychometric properties of the latent variable measures, great importance to academics. But but I think that what we need to do is move to an adequate measure. And here I would actually point to the work done by Chris Murray in DALYs. I think DALYs have not been a great measure in theoretical terms, but they're easy to measure, and we have measures for all the diseases. So the conceptual underpinnings are weak, but I think ease of measurement and implementation has meant that DALY has won the debate with the QALY, which I think is a more theoretically sound measure, but much more difficult to measure. So I think there's an ease of measurement issue, and that we can get sort of 90 or 95% of what we want with an imperfect measure. And the academics can fight over getting a more perfect measure. But from a practical point of view, it probably has little, it adds little value. Next slide. Oh, okay. So let me just summarize then and say my recommendations are essentially to focus on one measure for resilience. And it doesn't have to be perfect. It just has to be adequate for the purposes that we need. And that should be the focus both for implementation and empirical work. And then with an empirical work to get the routine measurement of outcomes in panel data so that we can actually study resilience with real panel data in multiple settings. Thank you.
Thank you very much, David. That was really interesting. If you have questions or comments, as I did during that really interesting presentation, please do put them in the chat so that you don't forget them. We've now talked about sort of the theoretical underpinnings of resilience and some different thoughts about measurement and what a variety of academics and practitioners are thinking about when they think about resilience, defining it and measuring it. We're now going to move into a presentation about doing resilience and what that looks like. And so I'm going to, can you advance the slide, please? Introduce my colleague, Isabelle Brumeau. She has over 25 years of experience in disaster risk reduction and resilience strengthening as project manager, consultant, and technical advisor. She's worked in Asia, Latin America, and the Caribbean, as well as Africa. She has led and supported a diversity of resilience activities and processes ranging from strategic planning to program design and implementation, advocacy activities, and evaluations. But her particular interests and strengths are linked to the development of technical guidance for practitioners and for capacity development. She works in French, English, and Spanish, and holds degrees in aid and development and disaster management. Over to you, Isabelle.
Thank you, Megan. Good morning, good afternoon, everybody. Next slide, Pradisha. Yes. So as practitioner in MIHR, we used this definition that USAID produced in 2020 for health resilience. So the ability of people, households, communities, systems, and countries to mitigate, adapt to, and recover from shocks and stresses in a manner that reduces acute and chronic vulnerabilities and facilitates equitable health outcomes. So as we discussed with David before, we're talking about shocks and stresses. We are talking about abilities of people, households, community systems. So that means capacities, capabilities. And we are talking about a final outcome and the progress and the improvement of this final outcome. And in our case, on health outcomes, positive health outcomes. Next slide. So when we're talking about operationalization now and using these definitions, we need to really think through an intentional conceptualization of our program and projects. And we need to be able to answer those four main questions to really justify our contribution to resilience strengthening. So the first question, and within the MIHR project working on health resilience, the first question is about the resilience for whom? And here it's really focusing on our target population. So our target population is women, children, adolescents, and youth. But alongside resilience, for whom we're also dealing with resilience of what? And here we're talking about the health system, the local health system, so community systems, family systems, and as well the local service delivery systems. So those are the main points that we will be targeting when we will be supporting resilience. Then the next question is about resilience to what? We're talking about shocks and stresses. In the MIHR context, one of the main issue, because we are working in fragile environments, are conflict and outbreak of violence and high level of insecurity. But also we are dealing with climate risks and mainly floodings, and then disease outbreaks, of course. So those are the shocks we are mainly focusing on. In DRC, for example, we also focusing on volcanic eruption, that in 2021, the latest eruption also severely affected the health system in the region where we work. The third questions, and that's the one that we'll be discussing more today, it's about how to strengthen resilience. So how we operationalize it really, and that the implementation strategies that David was mentioning earlier. So how do we do that? And that's a point I'm just going to answer just in a few minutes. And then the fourth question, it's about resilience to what end? So what are the outcomes we want to maintain or to improve despite shocks and stresses? And in our case, it's about reducing morbidity and vulnerability, morbidity and mortality, sorry, among the women, children, and youth over time, despite shocks and stresses. Next. So as we just heard from David, there is clearly and definitely a link between shocks and health outcomes. We saw that. So there's a need for implementation and operationalization of resilience. And there is also a dearth of evidence on what strengthens health resilience. So it's really important for us practitioners to develop, test, measure, learn from any intervention and an intentional intervention when we really integrate health, traditional health activities, and also traditional resilience intervention together to really support health, health resilience. So now I'm going to discuss a few of the intervention we are developing within MIHR. Next slide. So for example, this one, it's about the integration of a more resilience focus and approach into a traditional health intervention that I guess most of you will know, and which is already key as itself to strengthen health resilience, but we can still increase its focus on resilience if we really apply a risk and resilience approach. So it's about the community health worker assessment and improvement matrix toolkit. Most of you may know it. So it's a tool that's been developed several years ago. And within this tool, there's 10 components that are highly correlated with the community health workers program success, like looking at recruitment, supervision, training, and incentives for community health worker. But we felt something was missing because we were working in fragile settings and in places that were highly prone to other climate risks. So we decided to look at it more in depth and see where we could really integrate some more risk and resilience focus. And we came up with 3 new components to this AIM toolkit. One is on systems and structure for community resilience. So looking at how community health workers are supporting the systems and structures that would be working on preparedness and cohesion at community level towards more resilience. Another component is on the safety and resilience of the community health workers themselves, because they're working in very highly insecure environment. We thought it was really important to make sure that was also taken into account, so that they could at any time maintain and continue their supports to the community even during crisis. And a third component on risk communication and community engagement. This tool is available online. If you look at in the Momentum website, you will find those 3 new components that were already published. And through this work, we are hoping to contribute and strengthen sources of resilience within the community, looking at bonding and bridging social capital. We're looking at increasing self-care. We're looking at increasing self-efficacy, preparedness. We're looking at building human capital and improving health behaviors and social cohesion, which are all sources of resilience. Next slide. So still at community level, to complement the work we are doing with the community health workers, who are really key actors in terms of supporting and ensuring health resilience, is another activity which was more taken from the disaster risk reduction and resilience, traditional resilience activities, and where we integrated a more health-specific focus this time. And so it's about community-led action planning for health preparedness and resilience. So we've developed a process that a participatory process working with communities, where we support them in developing their action plan for preparedness and resilience, which includes aspects of surveillance, aspects of MNCH, so maternal, newborn, and child health, so how the community are going to access prenatal care, postnatal care, how the community also access family planning services or family planning items during crisis, and it also looked at other health issues and issues about WASH, and all those developed with it's community-led. So that's a complement to the community health worker AIM toolkit that we work on. Another example, next slide. So we were talking about community level. Now we're talking about higher up level, health service delivery level. So and mainly focusing on health facility, and the health facility at the local, at the last mile or first mile, sometimes as we say as well, where it's very critical to ensure that to support them in ensuring a certain level of continuity for the essential services during crisis. And so in health facilities, so since mid-2023, we had over 80 plans developed in 4 countries, so in South Sudan, Mali, Niger, DRC, and also now we are starting in also Tanzania and Sudan, where we supported health facility to develop their plans. And we already have some learning and anecdotal evidence of success. The same as for community, sorry, I forgot to mention, but the same in terms of community-led action planning, we already have some also anecdotal evidence of success. So this health facility emergency preparedness and response plan, so we support health facility in doing risk assessment, doing inventory of resources, and then 2 important things. It's the continuity plan for essential services, and at the same time for them to think about a response plan. Because what we've seen a lot in other actions. It's either the health facility develop a continuity plan without thinking of the response, or the health facility develop a response plan without thinking of the continuity of essential services. But as we know, at the last mile or at the local level, health facility have to cover both. And that's an important aspect they need to consider, how they will balance response to surge in needs and as well continuing essential services. So yes, other examples of what we've done for operationalizing health resilience. We have activities with youth, like the Youth Community Action Team, Youth Participatory Action Research, and where we, when we are working with them and doing training and other research, participatory research action, we have some sections and some modules on the role of youth for community health resilience. So what their role before, during, and after crisis, and how they can support together their community. Also with local partners, so local NGOs, we have a big capacity strengthening interventions in several countries, where we also included within the tool, the assessment tool, the capacity assessment tool, we integrated sections on risk and resilience, but as well in the partners' interventions on family planning, we also integrated resilience-focused activities. We also have a SBC, so social behavior change strategy, that is specifically focused on health preparedness and resilience. And we've also adapted several social behavior change tools so that it has an increased aspect on resilience. Another very interesting intervention we're working on in Tanzania and Mali, it's microfinance for health resilience at community level. So it's complementing very well the community action, community-led action planning for health resilience, the work with the community health worker, but also linked with health facility, EPRPs as well. Another example is with immunization and vaccination, with reaching every district, reaching every community or child, the REDREC intervention, where we also intentionally integrated aspects of risks and preparedness and resilience with our intervention. Several of those tools or activities have already been published on Momentum's website. Other will be in the coming months or before the end of our project, so stay tuned. And finally, next slide. One more aspect on measurement that also David was mentioning earlier, and what we've applied, we've tried to apply with this project within Momentum, is using panel data at country level, so in DRC, where we designed a recurrent monitoring survey, which was previously called a recurrent monitoring, recurrent monitoring system, now called, previously called survey. That looks at panel data at 3 to 4 months interval. And those data will help us looking at those, those 3 categories we were talking about resilience, shocks and stresses, capacities, capabilities, or sources of resilience, that now we're calling them, and then health outcomes. And so we are following them through every 3 or 4 months and trying to learn about that. So we are now, I think, going soon with the 3rd round of data collection. And coming up very soon, some manuscripts or articles being published, hopefully in peer-reviewed journal, where we will present learning learning from those these recurrent monitoring surveys, which we are working with Brigham Young University. I think that's my last slide. And
thank you very much, Isabel. That was great. Isabel has been traveling for days, so we really appreciate her being here and taking this on. Shows a lot of resilience. Please put questions in the chat or raise your hand. I see we have one hand and one question in the chat. And the question in the chat is actually something that I think is part of a larger question that I had. In thinking about, David, the work that you did with the DHS and trying to kind of construct a pseudo panel data set, and thinking about the RMS work that MIHR is doing in the DRC, and thinking about, you know, Kurt mentioned in the chat, Young Lives data, which is from 4 countries and follows a cohort of children across 20 years and includes information on shock. When we think about panel data and recognizing the importance of panel data, particularly as it pertains to resilience, are all health panel data equal, or are there certain variables that simply must be in those data or in that survey in order to answer some of these bigger questions that we have about resilience over time, or resilience kind of pre, during, and post shock?
Yeah, let me just address that. You know, I think that the use of the panel data depends on the question. I would say I also work in the aging field of surveys of people over 50. Those are mainly in developed countries, but they're now moving into developing countries, and there's a big interest in adding those in Africa. We have one in South Africa, and there are now pilot studies going on in other countries. And those are all panel studies, because there's a view in the aging literature that you really need panel data to answer the questions that they're interested in. And yeah, so, you know, the Young Lives data does have a link to climate shocks. And so it is possible to look at those questions there. When we started this work, there was an interest in particularly African countries for fragile settings, which is how we picked the 4 countries that we worked on, which didn't overlap with that data set. So I think panel data is useful for lots of things, not just resilience. I think it's sort of vital for resilience, but it's useful for lots of issues. And I think, you know, there's a question about what you want the data set to do. I would encourage more panel data. I think that the Congo data that you talked about is really useful. But I think there's also advantages to nationally representative data. Also, the sort of overlap between panel data sets and shocks, and to some extent, is chance. And there's an advantage to having large panel data sets where you get the overlap. Now, if you set up the panel data sets in highly fragile settings, I think you probably will get shocks, and so it will work. But there is this issue that you don't control the shocks. But I think that, you know, my view is that we need more panel studies and more investigation of resilience in panel studies, and then linking to some notion of resilience and how it affects, how measured resilience affects realized resilience in the empirical data.
Great, thank you very much. Over to Jody. I see your hand is raised, and then we'll address the questions in the chat. Jody, can you hear me?
Remember that we have a webinar mode, so they don't have their mics enabled unless we specifically tell the producer to. I'm not sure if Camilo can enable that mic for Jody. Can you do that, Camilo? Or should we have to only resort to writing in the chat?
Or maybe Jody can write the message in the chat, and then I can go to the next one. Isabel, there's a request in the chat for an example in which your activities have contributed to health resilience after a specific shock.
Hi, Leonel. Yes, I will answer the questions. I have several examples. I will just use one, maybe two. Yes, for example, in South Sudan, That's an example for the community action planning process that we've done in South Sudan, where that was, I think, several months back, just before at the beginning of the rainy seasons and the flooding season, the community, when starting seeing the level of the flood water rising, organized with the health facility the moving of certain type of medicines and other health equipment, health supplies directly to the community before the community was completely cut from the health facility. And so all the community, then the youth organized themselves to really carry out all the important supplies directly to the community. Another one from Niger also, where they realized the main issue when there's flooding also in some communities, where when the flooding cut the community from the health facility, they want to be able to have like safe delivery within the community. So in their small local huts, what they call the small dispensary at community level, what they were missing was equipment for realizing safe delivery in the community itself. So they all put some funding together and organized and made sure that their health, their small health hut within the community had a good bed and a good all good equipment, so that they could have like safe delivery within the community when when people were not able to evacuate when a pregnant woman was going to deliver baby. So those are two examples at community level, but we have also in Mali examples within security as well, some other examples. What we planning to also publish hopefully in a few months' time.
Thanks, Isabel. And I just wanted to point out a comment from Nancy Stroop, who leads our research monitoring and evaluation work and has led a lot of the work on the RMS, the recurrent monitoring system we were talking about, that RMS traditionally starts after a shock. And so it's directly related to a shock. And because in Eastern DRC, there's chronic shocks and stresses, we don't have to wait for the shock, which makes it a place where the RMS has been able to work fairly well. Question from Laura, how has complexity-aware monitoring been linked with Momentum's resilience work? Notably, is this a way that helps to connect the dots for country teams?
Well, I don't know if Beth Oderson is still on, but this is Nancy. The Merle team on MIHR and the SBC team have really been leading the charge with using most significant change, which is a complexity-aware monitoring and evaluation method. Up to this point, it's focused a lot on the SBC work, but of course the SBC work in MIHR is very much focused on and tied to resilience. So Beth really, she's done a lot of the trainings and trained the trainers. So if she's still on, she can probably speak a bit more to that, but we do use most significant change in MIHR in several of our countries.
I'm not sure she's going to be able to speak because of the way that this is set up, but I will say that aware monitoring work is also linked to collaborating, learning, and adapting, with the idea of bringing that into the bigger conversation around what's happening from a data standpoint. Isabel, yeah?
Yes, I just also wanted to mention and take some things that David also mentioned in this presentation about the ARCD toolkit, and the ARCD meaning analysis of the resilience of communities to disaster toolkits, which MIHR adapted for specifically health. So we have the ARCD health, analysis of resilience to community to disaster in health, for health, and which is a tool that we've been using for looking at health resilience at community level. It's a tool that is also linked with the community-led action planning tool and also with other tools like the community health worker AIM toolkit. So that's something all linked together. And we'll be also publishing the ARCD Health guidance document and the baseline that we've done last year on ARCD Health in 3 countries, in South Sudan, Niger, and Mali. And we've also done it in Burkina Faso now to show the results. And next year, we'll do the end line and see if we had any progress in community resilience. So we look at the community system.
Thank you very much, Isabel, for bringing that up. That's a great point. Jody, thank you for writing in your question, and sorry you weren't able to use your mic to ask it. Jody, this is a question for David. Jody's interested in learning more about the third factor that was referred to and the health systems approach. So example, process improvement that could be most effective or evidence-based in building resilience.
Yeah, I think the sort of thrust of what I'm saying is I think it's very difficult empirically to determine what is the most important component of resilience. You're really asking a lot of the data if you want to distinguish between individual household community levels and system levels of resilience and what each one contributes to resilience. And then within each measure of those, there are usually 5 or more factors that make up that measure. And you're really asking for estimates of impact of very large number of things. And, so the estimating the impact of a shock and the lag with all of these resilience measures, I think is not feasible. And I think going down that road is a sort of dead end because we just won't get we're not able to estimate that fine. And I think that it's more that we have a concept of resilience and maybe a very small number of resilience factors at different levels. But then we look at the impact of those and don't try to disentangle which one is doing the work. I think that's just too difficult given the data resources that we have. And it's really it's a field in which you can't have randomized trials, or very difficult to have, and that because it's this interaction with these random shocks. So I think it's a very difficult field empirically, and you're asking for more subtle estimates than is usual. So I really come back to this point that what we're set up for empirically is A causes B. And here you're looking at the interaction of things having effects. And it's a 3-way interaction, and that's a really complex thing. And if you say, I want to know which component of resilience is more important, and that's also going to vary across settings. And so getting at that, I think, is not really feasible. And so I would argue for a simpler approach and accept that we're not going to be able to say, this third factor is more important than the second, and we should focus on that. I think that maybe comes conceptually, but trying to get empirical evidence for that is going to be very difficult.
Thank you very much. And just to point out in the chat, Dan Wendo, who is our chief of party in South Sudan, provided a really good example of resilience in action due to flooding in South Sudan. And then Beth provided some more details on complexity-aware monitoring and just specifically most significant change. I think we're going to need to stop there. These questions are excellent, and I'm sorry that we're not going to be able to get to all of them. I do want to thank our presenters. This was a really rich and interesting conversation. I enjoyed it thoroughly, and I think the participants did as well. And I just wanted to point out, finally, before we leave, we have a few more MIHR-sponsored webinars on the horizon. Pradisha, could you please go to the next slide just so I can flag those for people? On July 31st at 8 a.m. Eastern, there is a presentation for assessing progress of SRH self-care in humanitarian settings, the 1-year anniversary of the global call to action. On August 31st, learning from supply chain challenges and strategies for reaching the last mile in fragile settings. And finally, in September, October, the role of the private sector in improving access to family planning and reproductive health care for youth and adolescents in Francophone West Africa. We hope you can join us for those as well. And thank you all so much for your participation and time today. Have a good day and evening. Take care.
Bye, everyone.
Bye, everybody.
Take care, folks. Bye.
Thank you so much, everyone. Take care.